Hello, I'm Ravi Vij. I'm Chief Medical Officer at MyCancerHaven. MyCancerHaven is a 501(c) organization with a mission to improve the quality of information, support, and care available to every person facing blood cancer. I'm excited to welcome you to our Roundtable series, CLL Today, Integrating Innovation into Everyday Practice. In today's episode, we'll be focusing on new and emerging therapies. In this discussion, we're joined by two key opinion leaders, Ryan Jacobs, who's director of the section of lymphoma and associate professor of medicine at Wake Forest University in Charlotte, North Carolina, and Dr. Adam Kittai, who's associate professor and assistant director of lymphoma research at the Icahn School of Medicine at Mount Sinai in New York. Welcome both.
Thanks for having me.
Yeah, thanks for having us.
This program is supported by an independent educational grant from B1 Medicines, and the program production has been provided by Cancer Communicator. Let's address first the current gaps in the treatment of CLL. Before we dive into the pipeline, let's see what we're missing today. So, Adam, I'll start with you.
Yeah. So I think that the two main places that we need more therapies or to figure out how CLL evolves over time is actually in the watch and wait time. And so we have about 20 or 25% of patients who actually never need treatment. But we do know, based off of longitudinal studies, that these patients do have significant morbidity in fatigue, infections, secondary cancers. And one of the unanswered questions in CLL is, do we intervene on that group of patients? And can we actually make a clinical improvement, or at least the quality of life improvement that we're looking for from those patients? And so I think that's an area of unmet need because I think it's a big pool of patients that we haven't even figured out how appropriately to monitor or treat them. The other one's a more obvious answer. It's in, I would say, triple refractory. So patients who've received both a covalent and a non-covalent BTK inhibitor, as well as those patients who've received a venetoclax-based regimen. So these patients who have seen our 3 modern day ways of treating CLL, we don't have many good options for them. And that's mostly where our newly developed agents are being explored. And so obviously having patients who are triple refractory to our main therapies is also an area of unmet need.
So, Ryan?
Yeah, I was going to focus a little bit on triple refractory as well. I think we might have gotten a little bit of some encouraging data from ASH this year with some real world outcomes with liso-cel, and it looks like maybe the ability to bridge to liso-cel with pirtobrutinib that wasn't there in the Transform CLL study because pirtobrutinib wasn't available at that time commercially. Maybe that's led to a bit better outcomes than we had previously thought with CAR T. But as we know, there's a lot of patients, particularly the very elderly with CLL, that may not have access to CAR T. So I fully agree, with Adam. And I would also say maybe even bringing it a little bit forward to double refractory. Yes, we have pirtobrutinib, but we know when the patients are double refractory, the PFS is not outstanding with pirtobrutinib. It's about a year. So if we could do better than that for those patients, that would be great too.
Great. So let's start off with some of the novel therapies. So BTK degraders. So BTK degraders are generating a lot of excitement. For example, BGB 16673, NX2127, NX5948. So how do you explain the rationale for degradation versus inhibition to colleagues? And what has you most excited and what makes you more cautious about this new class? So this one I'll give to you, Ryan, first.
I think the obvious thing that's the most exciting about BTK degraders is its ability to have activity even in mutations such as T474I, which we have referred to as a gatekeeper mutation. We see that sometimes after acalabrutinib, specifically the L428W that we call kinase dead, that we've seen at a bit higher frequency after zanubrutinib relative to some of the other BTK inhibitors. The ability for degraders to still have activity against those resistant mutations that we also see as even more prevalent in patients that are progressing after pirtobrutinib. So still having the ability to inhibit BTK across a greater spectrum of resistant mutations is, I think, the clear step forward that degraders will have. And I think, initially it'll fit in nicely as sort of a fourth line option potentially. But I know there's already thoughts about bringing it earlier. And maybe if you involve this more potent inhibition of BTK earlier in treatment, do you get better outcomes overall?
So, Adam, anything to add to that?
One of the interesting concerns about BTK degraders, which is still being identified and elucidated, is the resistance mechanism to the BTK degraders. And so one of the interesting ASH abstracts was looking at the resistance mutation to the degraders, and it was something called the A428D mutation. Lots of numbers there. And what's interesting about this mutation is that it does appear to confer resistance not only to the degraders and the other degraders, but also to all of the kinase inhibitors. So it's sort of a souped up kinase dead mutation. And so this is one limitation, that if it appears that this particular mutation happens even in earlier lines of therapy, right, it may just appear in these patients who have refractory CLL and bad CLL when you give the degrader in a late line. So we'll see if these mutations appear in earlier lines, but if they do, it might confer resistance to BTK as a class, which may really impact its ability to be brought forward to the front line. Now, one light about this is that we don't see as many mutations when we use things as time-limited therapy. And so if a degrader is developed as a time-limited therapy with a BCL2 inhibitor, it may have a stronger role in the front line than, say, continuous BTK degrader therapy.
So, Adam, what are the early phase clinical data in relapsed refractory disease and that stand out to you? The response rates, the depth, the activity in BTK and mutant disease. What has got you excited so far?
So far, we've seen data from the B1 compound and the Nurex, the second compound, and those two have been presented simultaneously at various conferences for the last year or two. And what we're seeing is that we see the typical response rates that we see with BTK inhibition. We don't see really deep, complete responses. We see mostly PRs and stable disease, which is to be expected when we're targeting BTK. But what we're finding, and what looks good, is the PFS on these particular treatments appears to be pretty good for patients who received covalent BTKI, especially. And now they're trying to enroll more patients who are triple refractory, like we had discussed, to see the efficacy in that line of therapy. And so we'll see how it all plays out, but the PFS with these drugs appears pretty robust in the number of years. And so you can imagine a patient who starts on a covalent BTKI, gets 5 to 10 years, then gets a non-covalent BTKI, gets another 2 to 4 years, and then gets a BTK degrader, it gets another 1 to 2 years. And so that's a lot of years to add up for our older, for other patients with CLL.
And Ryan, anything to add?
Yeah, I think just the initial activity seen in the, albeit small number so far, but the patients that have progressed on both covalent and non-covalent BTK inhibitors, that we still have activity there is exciting. Tolerability has looked pretty good, and we'll see if there's some differentiation between the two, because from an activity level, it looks like they're quite similar so far.
Agreed.
So, Ryan, as far as the safety profile goes, are these like class-like BTK toxicities, or are there any new off-target effects that are being seen?
I haven't seen anything in terms of a new signal, and I would say sort of along the line of what we saw with pirtobrutinib. We see some of the same toxicities, but at lower rates, at lower grades. It's hard to compare across early phase 1 studies. Initially, the discontinuation rates due to toxicity from the Nurex degrader appear very, very low. The B1 degrader has at this point a bit higher rates of reported discontinuations due to toxicities, but I haven't. Most of them seem like they were possibly from infection. It's hard for me to see any new signals.
And Adam, you want to weigh in?
I agree. We need more time and more patience. As we know, BTK toxicity accumulates over time. And so we need more time and more patience.
And I think Ryan already weighed into this question, but Adam, how do you see them fitting into the paradigm at this time?
So far, I see them fitting into the patients who received prior covalent and non-covalent, at least at this moment. But that opinion may change if we see some better efficacy signal that might suggest we should use it in the second line after covalent or even frontline, or if we see some synergism between the degraders and some other molecule. So I think time will tell, but they do look like they work effectively and they are pretty safe. So I'm excited to see how they are developed into the future. But as I said earlier, I think we need more time, more patience.
So let's shift gears to the next generation BCL2 inhibitors now. So Ryan, let's talk about what's coming after venetoclax. We're seeing data with second generation BCL2 inhibitors. How do you see these agents fitting in to the treatment landscape?
Focusing a little bit more on sonrotoclax, that appears to be with sort of the greatest potential to jump into the field sooner rather than later. I think the initial thought would be for our patients that are previously BCL2 exposed, can these agents be effective for rechallenging? Can you rechallenge with sonrotoclax and still get really good response? Perhaps even better than what would be expected from rechallenging with venetoclax. Is there a potential with its higher potency that's been recorded? Is there potential to maintain efficacy? But I think ultimately with head-to-head comparison, there's going to be interest in just sort of replacing venetoclax as the BCL2 inhibitor of choice. And of course, we'll see how the head-to-head comparison looks. I've got that trial open. It is for relapsed patients, and they could have been previously treated with venetoclax as well, or BCL2 naive. So they're going to look at both patient populations. So that'll be quite interesting. But as Adam will attest to, the majority of patients with our treatments being so good in the first line, to capture the largest number, you're going to have to find your way into frontline treatment, and time to find treatment is where the field seems to be moving. And so I think the biggest way that sonrotoclax could make a splash is with combination with zanubrutinib in a time-defined way, given over 1 year for previously untreated patients. And that trial I'm referring to is the Celestial trial, which completed enrollment over a year ago. So that actually might be where sonrotoclax jumps into the field first.
Adam, do you agree?
Yeah, I'm very interested to look at the Celestial study and find out the results, number one. Number two, I want to highlight one thing that may inhibit the adoption of sonrotoclax, and that's the ramp up, right? We still haven't gotten a defined ramp up for sonrotoclax. It's been used as a odd daily ramp up. It's also been used as various weekly ramp ups. And so one of the biggest barriers to implementing venetoclax is the ramp up, right? The requirement to get labs before, labs 68 hours later, and then 24 hours later, and then to hospitalize the patients who are at higher risk or have poor renal function and medium risk for tumor lysis syndrome. And so I think one way that sonrotoclax might make a major impact is if it makes the ramp up easier based on the FDA label. And so I think if all things are equal and we don't really know which one works better, if sonrotoclax simply hits that low bar of making the ramp up better, we may actually adopt it faster than we otherwise would.
So Adam, what do we so far know about the efficacy and safety of these second generation BCL2 inhibitors, both as monotherapy and in combination?
They look good, but we don't have any comparative data. One of the things that I thought looked specifically good about the sonrotoclax data is the time to response was really fast, which was nice to see. But whether or not fast time to response equivocates to actually long-term durable remissions is yet to be seen. It's probably true, right? But we can't say for certain. And so I think we need to see these randomized trials read out before we can make a claim that sonrotoclax is the better BCL2 inhibitor. I don't think it looks any worse than venetoclax by any means. And so that's why I was saying that, if it just gets through that bar of making it easier to ramp up, that might be enough for us to use it widely.
Ryan, anything to say about the efficacy and toxicity signal so far?
So I agree with Adam. No clear idea of efficacy wise whether it's superior. There's some, I think it's more preclinical reports that it could maintain efficacy against certain mutations that have developed in venetoclax resistance patients. But it, unlike BTK, the mechanisms and routes to BCL2 resistance are not as well known, and there doesn't appear to be one dominant mutation that we can look at specifically. So we're just going to need that head-to-head data on efficacy. It will be a little bit difficult to tease out necessarily in the Celestial study because it's paired with zanubrutinib and the control is venetoclax. But the head-to-head study in the relapse setting, which is BGB 11417303, that's going to be a direct comparison to venetoclax. So that'll give us with anti-CD20. So that'll give us a more, I think, a better understanding. From a toxicity standpoint, I think it seems to just be the in-class expectations of watch for neutropenia, and whether the neutropenia rates are any better or worse, we'll see. I haven't gotten a clear impression of that so far. I will say, both agents, when you follow the ramp ups, however they may be designed, have very low TLS.
So, Adam, another group of drugs that has shown remarkable efficacy in lymphoid disorders, especially diffuse large B-cell lymphoma, follicular lymphoma, are the bispecific antibodies. What can you tell us about the data in CLL, either CLL that is transformed to Richter's or CLL itself?
So currently we have the most robust data with epcoritamab. The reason why bispecific antibodies have had a slow start in CLL is twofold. Number one is that we have really safe drugs that are very efficacious currently. So it's difficult to bring about a bispecific antibody that comes with real risk, like cytokine release syndrome, into the fold. And additionally, because of the high tumor burden of the circulating CLL cells, there was concern that with that burden, we might see higher rates of CRS and neurotoxicity. So the most recent update we have is for CLL. We do have some Richter's also. And that was the epcoritamab data that looked at including an additional step-up dose to mitigate CRS. And what they did was they did mitigate CRS. So with the extra step-up dosing, the rate of grade 3 CRS was reduced down to all grade 2s for the most part. But follow-up was short. And so it did look like it was inducing responses. But if I remember correctly, and maybe Ryan knows this data more clearly, I remember it being something like 5 or 6 months as being median follow-up. So we need more follow-up to see if these responses are durable. But it was also similar to the degrader studies, exciting to see that epcoritamab was effective in patients who received our prior lines of therapy that we use, like the BTK inhibitors and BCL2 inhibitors. Now, with Richter's, it's sort of a different ballgame in that we have no real effective therapies. We have therapies that work for 1 or 2 years, but anything that leads to a response or has any sort of durable response is looked at kindly. And so there's the epcoritamab data for Richter transformation, which was recently published, which had a small number of patients, but still looked like it was inducing responses above 60%, which is sort of the standard for Richter transformation, which was nice to see. And, knowing that we now have T-cell engagers and NCCN guidelines for Richter's with epcoritamab gives it a new novel way of treating the disease, which really doesn't have many good therapies at all.
So, Ryan, what do you think about these bispecific antibodies? And do you think these are going to someday move into earlier lines of treatment as well?
Well, I think Adam did a good job of talking about the reasons to be excited. And I would say, before we got the CAR T real world data from ASH, the bispecific data looked much more promising than the CAR T data in a seemingly somewhat similar refractory patient population. To sort of rain on the parade a little bit, I did hear that they are not pursuing epcoritamab in CLL. So I don't know if we'll ever see it. And it was not from a lack of efficacy. It was just that they feel like other treatments are advancing to such a degree that are mostly oral and easier to take, that there's just, I think it was maybe more of a business decision. So I don't know if other players will move in. I will say I've been involved in research with a CD19 bispecific called Suravatamig, and it is still interested in investigating activity in both the relapse refractory population as well as maybe as a consolidative effort for first line therapy, which I find pretty interesting. I don't know how scalable that would be, but very interesting scientifically.
Well, I thank you both for your views on how these novel therapies, BTK degraders, BCL2 inhibitors, and potentially bispecific antibodies could enter and the landscape of treatment. Let's talk now about data that has been generated on novel covalent BTK inhibitors. Adam, what do you say?
So we had two studies presented at ASH, pirtobrutinib versus BR in the front line, which was largely accrued ex-US because we don't use BR as frontline therapy for CLL in the US anymore. And it obviously showed a improvement in PFS, which was no surprise. And that was the registrational study. So we'll see if pirtobrutinib gets approved in the treatment-naive space. There's been some issues within the US of approving things where we don't include US participants. So we'll see if that actually gets approved. The more interesting study was the pirtobrutinib versus ibrutinib study, which enrolled both patients who were relapsed refractory, who did not receive prior covalent BTK inhibitor, and also patients who were treatment naive. And that's the more interesting cohort. The problems with this study was that they used overall response rate as their primary endpoint. So it's kind of a strange primary endpoint, but it was a non-inferiority study. So pirtobrutinib was non-inferior for overall response rate compared to ibrutinib in the relapsed refractory and treatment naive setting. So that's the one thing that the study showed. So it met its primary endpoint. But what the most interesting thing here was that they had PFS as a key secondary endpoint, but they did do a strong job of wording it to say that even though the PFS did meet statistical significance by just classic standards, per their cutoffs in the way they designed this trial, it's not yet statistically significant based on the way they designed it. But what was most interesting was that pirtobrutinib looked like it prolonged PFS compared to ibrutinib in the frontline space. So we'll see how this data plays out over time, whether this PFS benefit continues to show. But how I think about it is that if pirtobrutinib truly has a PFS benefit compared to ibrutinib, I would likely use it compared to the second generation of BTK inhibitors for older patients who I expect may only need one therapy, because it does look like it's safer from its atrial fibrillation risk, which continued to hold in this randomized phase 3 study. And also, I would like to see some mutational data to look at whether or not those patients who develop resistance to pirtobrutinib have those kinase dead mutations, and to see whether or not that might impact overall survival. But I have a feeling that the mutational profile might look different in the frontline setting because we're dealing with less advanced CLL, but we'll see how it looks. So I think that there's a strong argument to using pirtobrutinib in the front line as a continuous therapy if it beats ibrutinib from a PFS standpoint, and if the safety continues to hold, and if the mutational profile at progression does not show as many of the kinase dead mutations as we're concerned about. In terms of its comparison to nebtabrutinib, we don't have that data. The kinase inhibition of nebtabrutinib appears to change every year depending on what wants to be highlighted by the company. And so we'll see if its off-target effects have any influence on efficacy, but we need to see comparative data. And I do believe they are running a comparative study of nebtabrutinib to pirtobrutinib. So we will eventually have that.
So Ryan, what do you think about pirtobrutinib and nebtabrutinib?
In short, I'm in agreement of with what Adam was saying. If there's frontline approval, I think the ideal patient would be the older patient that's maybe ever going to only need one treatment. Then you don't have to worry about the sequencing question, and it's maybe not somebody that you're, for one reason or another, based on preference or whatnot, you're maybe not as interested in time to find therapy. As someone that, I'm very interested in and sort of champion time to find therapy as sort of a move away from treat to progression approaches for, I feel like, most CLL patients. With some exceptions, I can begrudgingly admit I've been quite surprised with the somewhat limited, but still worth noting, data with pirtobrutinib prior to covalent BTK inhibitor data. We've actually seen a little bit in mantle cell that's quite impressive too. But if I would have guessed how a comparison would look, Perto to ibrutinib, I would have guessed similar efficacy and better tolerability. What we got is, particularly in the first line patients, a very significant, I know they can't claim it statistically yet, but a clearly big numerical difference with very little 18 months of follow-up. And so to have that difference so early, and it wasn't purely from just toxicity issues. Actually, in that early comparison, discontinuation rates from toxicity were the exact same, which was also surprising. So there's something going on there, it seems like, non-covalent before covalent, that is striking, and I'm impressed by it. But I think at the end of the day, it's still not going to move me off from wanting to still do time-defined therapy where I can for the majority of first-line CLL patients. I have less experience with nemtabrutinib, so I don't have a whole lot to say. I think it's going to be hard for another non-covalent to break in the space when you already have degraders that are also going head-to-head with pirtobrutinib in the relapse setting. So that's going to be quite a crowded space for nemtabrutinib to jump into.
So, Adam, for the community hematologist oncologists watching this, what do they need to have in place? Infrastructure, monitoring protocols, patient education to adopt these novel therapies when they become available?
Pirtobrutinib, not much. I have used a lot of pirtobrutinib. It is very well tolerated, very similar to the BTK inhibitors. And so if you're very familiar with implementing a BTK inhibitor, you can just swap in pirtobrutinib without much issue there. No issues. I think the biggest change will be with bispecifics, right? So, the adoption of bispecifics in the community has been slow because, epcoritamab is given weekly for the first few cycles. Glofit's given weekly for the first cycle, and Lo's in the same. And they also come with real risk like cytokine release syndrome and neurotoxicity. And so working with your partners who have very good familiarity with these drugs, making sure you have tocilizumab on site, maybe farming out the ramp up to the academic doctors and then taking them back when they start, getting these drugs monthly. That's going to have to be coordinated between the community practice and the academic doctors until the community practice doctors are comfortable with giving the bispecifics. But obviously, we're very far away from getting a bispecific approval in CLL. And for the most part, the community practice doctors are going to be very familiar with the bispecifics and with non-Hodgkin's lymphoma. And so it should be a pretty easy adoption once it gets approved, if it gets approved ever for CLL.
And you, Ryan, what would you give as pearls of wisdom?
I think you highlighted well. It's quite easy to incorporate things like Perto. I think when the degraders become available, it also will be quite easy to integrate. These are well-tolerated oral treatments. The one caveat is with sonrotoclax, I think people will have to potentially learn a whole new dose ramp-up scheme, and so we'll see how much of a barrier that is for uptake there. I do hope, as for more aggressive lymphomas like Richter's, where I do think bispecifics will be a big improvement in expectations for that patient population. I do hope that more providers will get comfortable using bispecifics because they're just going to keep finding their ways into more and more patient populations that they can help out.
Are there any emerging agents, combinations, incoming data readouts in the near future in the area of CLL, Richter's, that community oncologists should have on their radar in the next 1 to 3 years?
In terms of 1 to 3 years, I think we've done a pretty good job of highlighting what's likely to be coming between the degraders and the sonrotoclax, the next BCL2 inhibitor likely to come. You've mentioned, we'll see if nemtabrutinib can find a role. There's this other sort of dual covalent, non-covalent BTK inhibitor called rockbrutinib. It has the best name, I guess, but we'll see where it potentially fits in. I personally referred a triple refractory patient to that trial, and he got a little over a year of response. So that was great for that patient. Beyond the 2 to 3 year outlook, we'll see about potentially new targets for things like a MALT inhibitor that's seen some activity, and I mentioned a CD19 bispecific that might find some utility.
And so, Adam, is there anything you want to add to that list?
So in the randomized phase 3 studies that have fully enrolled, there's a lot of MRD-directed therapy designs that are occurring. And so I think in the next few years, we might be doing MRD-directed therapy more, meaning that we might have rules where if somebody's MRD positive, we might continue therapy for another 6 months or a year. And so I'm excited to see how those data play out, because I don't think MRD-directed therapy is quite ready for prime time in most patients. The other trial that I'm specifically really excited to see is the EPCOR plus pirtobrutinib study for Richter transformation run out of the German CLL group. And the reason why I'm excited about it is that there's really good data to support the use of BTK inhibitors to boost the function of T cells. And so I think any bispecific study that gets put forward should be a combination with BTK inhibitor study. So I'm excited to see that data. Additionally, just a comment on it is that anybody who I am referring for a liso-cel for CLL, I always use a concurrent BTK inhibitor, and usually it's pirtobrutinib. And the reason is because it boosts the effect of the CAR T based off of basic research as well as some clinical data as well. And so usually when I'm putting somebody on pirtobrutinib who's received prior covalent BTK inhibitor and BCL2 inhibitor, I'll continue the pirtobrutinib through leukapheresis, through the Flu/Cy, through CAR T implementation, and then 90 days afterwards. It doesn't seem to add toxicity. If anything, there's data that show that it mitigates toxicity, and it should improve efficacy. And we have some data from the ibrutinib plus liso-cel data that was presented by Dr. Weirda that does show that it does look like it's better than liso-cel by itself.
Okay, so as we wrap up, I'm going to ask both of you, what are your key takeaways from our discussion on emerging therapies, and what do you want the community hemoncs to walk away with today? So, Ryan, you get to go first.
Yeah, we've made it through this discussion so far without referencing the FDA approval that is, the first time that we've had an oral combination available that's time-defined. And it's, of course, I'm referring to the acalabrutinib venetoclax combination that has been on the NCCN guidelines as a category 1 recommendation for some time now, but it's great that we have the FDA approval. You don't have to worry about insurance coverage for that. And so my parting thought to community providers would be to be sure and ask your patients, when talking to them about treatment options, how important length of time on treatment is for them, because I think you'll find the majority are going to tell you that time to find treatment is a much more appealing prospect to them than treat to progression, and especially when it's all oral. And luckily, this combination appears to be effective in the majority of patients. Maybe the highest risk, deletion 17p, you wouldn't necessarily go to that one first, but really most patients, this is I feel like a really great option to have. And we'll see if in the future, if it looks like, sonrotoclax and Xanu might be better, but I'm just really happy that we finally have an FDA approval of oral time-defined treatment in the front line.
So, Adam, you get the last word. What about your view on emerging therapies, and what do you want the hemoncs to walk away with?
I'll kind of echo what Ryan said in that at this point, we have a lot of drugs that work really well for CLL. And with the approval of acalabrutinib and venetoclax, what makes it great is that it's a all-oral combination that appears to be very safe with an easy ramp-up that's time-limited. And so as we move forward in time in the treatment of CLL, we're really seeing these agents come out that are safer and just as effective as what we currently have. And even though the efficacy is not leaps and bounds better than what we've seen, I think safety here is super important, because these patients are likely to live long lives and be intermittently treated over the course of that time or treated with continuous therapy. And so I think, in my opinion, as we move forward in CLL care, safety is key. We have to make sure that our drugs are as safe, if not safer, than what we currently have. And we do have a bunch of drugs in the pipeline that do appear to be that. So I think in the world of CLL, our patients are living normal life expectancies. We're coming out with safer drugs. The next step is cure, like a safe medication that actually cures patients so they don't have to be retreated. And I think we'll get there. It's just a matter of time.
Well, thank you both for a terrific discussion. A lot has changed, and these are complicated decisions. And we really appreciate you sharing your expertise with us today. Thank you.